This is the new version of PowerPoint that I hate.
Oh, there's a new version?
Yeah, it's like you just can't make it give you your.
I think you can actually. I don't know if it's just started, but we don't want to look at the next slide, right?
What's
Okay, is that better?
Yeah.
Is it weird? Oh, whoops.
I don't like this new version of PowerPoint. Everything I knew how to do, I no longer can do.
Done. Now it works, right? What's wrong with this? Can I close it?
Actually, sometimes there's two things open. One is the presentation, and one is the.
Which one's the presentation? This one?
Yeah, I think so.
Like,
That's a little weird.
yeah, it's up there.
That's bizarre.
Yeah. Okay. Does it move? No. Okay, can we close it out and then?
Yeah.
Is it saved on the?
Yeah, it's on the desktop. I hate this new version of PowerPoint.
Where is it? Social.
Ever had this problem before?
No, today's the first day I've even seen this version.
I hate it because I did some editing and everything is different. Like all the things from the older versions of PowerPoint. I think one of these sometimes will do it.
No, that's to black out the screen.
All right.
No, it's to see all the slides.
Okay. I seem to remember there was one thing that let it duplicate slideshow. I think that works.
You don't need to.
Well, good morning. Now that we've got the new version PowerPoint glitches figured out, we're just going to get started. And again, I'm Dan Donovan. And today we're going to talk about therapies for both type 1 and type 2 diabetes. And we're going to focus on insulin as well as the other glucose-lowering agents. In years gone by, we used to be a talk that was insulin and other hypoglycemic agents, but now we have drugs that make blood sugars better that don't cause hypoglycemia, so it's better to call it glucose-lowering or anti-diabetic agents. Again, my disclosures, I have grant and research support from the NIH, currently from Novo Nordisk, Merck, AstraZeneca, and also have done some consulting and received honorarium from Novo, Merck, AstraZeneca, Lilly, and Sanofi Aventis. And as I mentioned on Tuesday, probably in my 22 years of doing clinical research here, I've worked with every single company that ever made or currently makes a drug related to diabetes, and it's been a great learning experience to participate in some of those clinical trials. So today, we have some learning objectives. I think these were left off on the one I sent to Betty, but I think she posted the newer ones, to understand the role of insulin therapy in type 1 and type 2 diabetes, and to understand how pathophysiology can guide us in a rational choice of anti-hyperglycemic therapy. And so I'd also like, in addition to insulin, for us to understand the role of many people consider the most important non-insulin therapies in the management of type 2 diabetes, although that keeps changing. I joke, you put 10 endocrinologists, 10 diabetologists in a room, you get 13 different opinions. So what are the most important is a moving target. And actually both the American Diabetes Association, whose meeting is in Boston, so after I'm done here, I'll go to my office to get on a train and go to Boston to learn about all the new stuff in diabetes, has just come out in January with their revised guidelines. And at the end, I'll show you kind of their little algorithm. In addition, the American Association of Clinical Endocrinologists, the American College of Endocrinology, came out in April with their revised guidelines, and they differ from the ADA in some degrees, and we'll talk about that. So, just a little chat for a moment before we go on to the meat of the talk, and that is in your careers in medicine, you're going to hear a lot of stuff, and it's going to be taught to you as if it is fact. But I would suggest that we beware of dogma. And why is that? Because today's dogma is tomorrow's malpractice. And we've seen that over and over again, that ways of thinking about disease states, ways of thinking about treatment sometimes turn out to be totally wrong. And so we've always got to reevaluate in the light of new evidence. We live in an era of evidence-based medicine. And it's probably still going on. We learn more. Even the guidelines for diabetes have changed because we've learned more. I think the classic example is the poor guy. It used to be said, no acid, no ulcer. And the poor guy who came up with the bacterial hypothesis almost got kicked out of medicine, but he was right. And so we sometimes have to change our favorite way of thinking about things or drugs. Drugs come in and out of vogue, and they seem perfect, and then we identify problems. So again, just caution. We're always learning. You're going to be learning for the rest of your life. Just for a moment on the glycosylation of hemoglobin, we know that that's part of the pathophysiology, that there's non-enzymatic glycosylation of glucose to various proteins, amino acids. That actually has a brief period of time where it's reversible. But once it undergoes this Amadori rearrangement, it's a permanent attachment. And that's not good for structure and function, because then these things can cross-link and form advanced glycation end products that are a problem. But we can use this phenomenon to help us in managing patients with diabetes. And so I take this time to talk about this. This is not a drug, but it's really the outcome measure in all the trials, because the hemoglobin A1C gives us the best indicator of the recent glycemic control over the past 2 to 3 months. Kind of it's a weighted average. That is assuming a number of things, that your red cells are actually living 100 to 120 days. Remember, they're born, they lose their nucleus, they're full of hemoglobin, they're floating around. They only use glucose as an energy source because they don't have much other cellular machinery left over. And they're really kind of a weather balloon floating around in the milieu of glycemia. We know from the law of mass action, the more glucose you have, the more glucose will push this reaction through Le Chatelier's law. And so the higher the glucose, the more glucose will be attached. Also, red cell half-life will determine. If your red cells happen to live longer than 150 days, your A1C will be higher. If they live shorter, they'll be lower. So every time we have an assay, we have to understand what the limits are. But in general, it's an objective measure of glycemic control. It really indexes risk of complications for patients in type 1 and type 2 trials. We now have ample evidence, at least for microvascular complications, that better glycemic control using A1C as kind of the outcome is associated with a marked reduction in either development or progression of microvascular complications. The macrovascular story is a lot more complicated, and we're not going to go through that today. So it cannot be manipulated by the patients. Many patients will starve themselves before they go to the lab, and their blood sugars will be perfect, but their A1C may come back at 12. It's not affected by meals or acute glucose changes, and it's a very precise, reproducible. This method is traced. There's a standardization throughout the world. And, in a number of studies, we can kind of relate the hemoglobin A1C to the estimated average glucose level. So if you're looking at an A1C of 6, which is the upper margin of where normal is, you can see the average blood sugar is about 126. That includes fasting and what happens after meals. And in general, a 1% change in A1C is around 30 milligrams per deciliter of glucose. The other thing, a caveat about A1C, in general, the American Diabetes Association says we should aim for an A1C of less than 7 for most people. We can go lower, less than 6.5 or 6 in patients who don't have other comorbidities, or are not at risk for hypoglycemia. And for older patients, we may want to raise it into the high 7s or maybe even the low 8s. So we're really individualizing our risk. But when we use the A1C, it's very interesting, looking at both fasting plasma glucose and postprandial glucose. At very high A1C, so this is 10.2, we see that's about 240 milligrams per deciliter of glucose, that most of the contribution to the A1C is coming from where they started the day. So if you start the day high and you're having your post-meal spikes, you're going to stay high. If you just get the fasting down so that you're getting closer to goal, then the postprandial component, what's happening after a meal, is becoming more important. And so we're going to mention it a number of times. Remember, I said on Tuesday, you'll need to hear things at least 3 times before they stick in your head. So I'm not repeating myself because I'm demented, but it's really a teaching tool. And so you've got to think about fasting glucose, and you've got to think about what happens to postprandial glucose if you're going to take adequate control. Just going to repeat this slide quickly that I showed on Tuesday, that actually glucose regulation is quite complicated. This is a very simplistic diagram. The plasma glucose is going to be a function of the rate that glucose enters it through the liver or through the stomach and GI tract. Remember, when we ingest carbohydrates complex, we break them down and absorb them as glucose. And the rate of disappearance into the tissues. So the pancreas is really important. The beta cells make insulin. We hope to suppress glucagon, which we don't need in the fed state. The other hormone, amylin, is secreted, co-secreted with insulin, and is a neuroendocrine hormone that has an effect on decreasing food intake. It increases or reduces satiety. It can actually slow gastric emptying, and it may also have an impact on postprandial glucose. If you cut the vagus nerve, no effect of amylin exists. So it's really a neuroendocrine hormone. And then we also mentioned the incretin system, which is getting a lot of attention. It's a very important system, and we now have targets for therapy. Each of these things is a target for therapy, including other aspects of the brain in which there may be sympathetic overactivity. So in response to food intake, we make glucagon-like peptide 1, which comes from the L cells in the distal ileum and colon. And it has a number of interesting effects, which are important for pharmacology, that it can also lead to a decrease in food intake. There are receptors for GLP-1 on the stomach, and it can slow gastric emptying, which is actually increased in type 1 and type 2 diabetes early on. Gastroparesis is neuropathic, is a late dreaded complication of poor glycemic control. So actually, many of our diabetics, we're delivering glucose more rapidly. And it stimulates insulin secretion from the beta cells in a glucose-dependent fashion. I'm going to demonstrate what that means as we talk about GLP-1 analogs. And it also suppresses glucagon secretion. How it does it exactly is a bit controversial. It looks like it may be an indirect mechanism rather than a direct mechanism. And of course, we have GIP, glucose-dependent insulin-trophic peptide, which used to be gastrin inhibitory peptide. Things get named sometimes for the first function that are discovered. It may not be their primary function. And these are secreted by K cells in the proximal small intestine. So both of these are rapidly released in response to a meal. So there's got to be some neural communication in the gut. And as I mentioned, GLP-1 stimulates both first and second phase insulin secretion, and GIP stimulates first phase insulin secretion. So what are our goals? Well, we have similar goals for the treatment of type 1 and type 2 diabetes. We want to achieve as near normal glucose levels as possible, safely, and we want to prevent complications or reduce the risk of progression for people who already have complications. And certainly, we'd like to optimize quality of life. Having diabetes can really impact someone's quality of life. It requires a lot of patient education. It requires currently the use of self-blood glucose monitoring. I'm still very jealous when I see the pulmonologist walking around with a little pulse oximeter. I'm like, I want one for glucose. And we were promised it 20 years ago, and it still hasn't happened. So it's really rough to be sticking fingers, but it's necessary. And also, now we've got continuous glucose sensors that are getting better, that we can use as an adjunct, but you still got to poke your finger. And it hurts, even with the fine little lancets. Many of our injections don't hurt. It requires attention to nutrition, carb content, complex carbs. Exercise is very important, especially in our type 2 patients who tend to be overweight or obese. The appropriate use of pharmacology, and then really observing patients, checking the feet, detecting and treating complications, annual eye exams after the 5 years of type 1, starting with patients with type 2 diabetes because you have no idea how long they had the disease. And so we're going to talk about insulin therapy, predominantly in type 1s, but some of these principles can apply to type 2s as well. In general, physiologic insulin delivery is about half basal, that is, if you're not eating, you've always got insulin around. The other half of insulin is required to deal with the ingested carbohydrates. So in general, in type 1s, estimates have been 0.6 units per kilo is a total daily dose, up to 0.9. Sometimes people require a little bit less. Adolescents require more because of all the pubertal hormones that are going on. So if we keep that in mind, we want to think about how do we deliver insulin physiologically. Now, this is data from the Diabetes Complication and Control trial, the first trial, actually, that demonstrated that better glycemic control made a difference for microvascular complications. Before that, many people thought if you're going to get diabetes complications, you're going to get them no matter what, because we saw people with good control, by checking their urine, which is too late, and people with bad control, good control people who got retinopathy, and bad control people who never did. But it's very clear from this trial. So for every 1% reduction in A1C, you have a significant reduction. It's like 60% in retinopathy. This other curve, however, is the risk of serious hypoglycemia. That means it required the attention of another person. And there's I don't know if the story is true, or maybe apocryphal, that one of the people who died during the DCD trial was not a subject, but actually killed by a subject who was driving with hypoglycemia. So this is a trade-off. When we're using insulin, insulin, the way it's secreted, is secreted in a pulsatile fashion from the pancreas, goes to the portal circulation, hits the liver first before it comes back out to the periphery. When we're injecting insulin, we are just providing it. It's already going into the peripheral circulation. And we're not giving it in a pulsatile fashion. So none of our insulin delivery methods are completely physiologic. And so there is an increased risk for hypoglycemia. Now, one of the things that's changed is these new insulin analogs that give better time action profile we'll talk about are better. Our insulin delivery devices, our pumps, our continuous subcutaneous insulin infusion devices are much better, but this is still a big problem. One of the limiting factors is the risk of hypoglycemia. So our glucose levels, and we saw these curves on Tuesday, are maintained in a very narrow range in response to meals. And because we secrete a lot of insulin, exactly the amount that we need. So when we're trying to think about how we physiologically replace, and in type 1 diabetes, you've got to do both. They cannot be without insulin, or they risk going into ketoacidosis. We need to provide some background insulin and some prandial or bolus insulin. That came from the pumps, and you press it and give yourself a bolus. I like to think about prandial insulin to kind of meet the needs. But again, you can see it's not perfect, but we're doing better than we were able to do before. So we have a number of types of insulin and insulin analogs available. We've got 3 short-acting insulin analogs, and I'll describe the mechanism of action. We'll talk about Aspart and Lispro. They're the most commonly used. We will talk about the human insulins, regular and NPH, and why they don't have such great time action profiles. Long-acting analogs such as glargine or Dedamer. In terms of using things in pregnancy, only the short-acting analogs and the long-acting analog Dedamer have actually been given approval to be used in pregnancy, but the human insulins, regular and NPH, are also okay. Glargine, despite being one of the most popular long-acting insulins, has not been studied in pregnancy and is still classified as category C. There is a new insulin, which I didn't include here. It's Technosphere Human powdered insulin, and it's an inhaled insulin. Gets a more rapid peak, but it's got baggage. You have to do pulmonary function tests before using it, pulmonary function tests after using it. I haven't used it. Have you? No. Yeah, so I don't know. We had other inhaled insulins, but we're going to focus on the stuff we got available. So there are problems with human regular insulin, which is it's exactly the same sequence as human insulin done by recombinant DNA technology. The problem is insulin aggregates as a hexamer with a zinc molecule in the center. And the only way you can get insulin to bind to its receptor if it's monomeric. And there's a delay in the response to insulin. Patients need to plan ahead, take it 20 to 45 minutes before the meal. What if the meal doesn't come? there's a risk of hypoglycemia, there's a mismatch with postprandial hypoglycemia, and it actually has a pretty long duration of action. There's still some insulin on board, even up to 12 hours a day, and so there's a potential for late postprandial hypoglycemia. So our short-acting analogs have really been in advance, and you can see with rapid, regular human insulin, it's crystals, it's dissolving slowly. With modifications to the primary structures, we'll see in the next slide, the rapid-acting insulin analogs actually dissociate and become monomeric much more quickly, so give you a much better time-action profile. Still not perfect. And they limit postprandial peaks, which is what we're trying to do. They reduce late postprandial hypoglycemia, but sometimes they're not lasting long enough, and you may be at risk for developing hyperglycemia a little bit later. And in type 1s, because they're so short-acting that the regular peaks could merge, you need basal insulin on board, because patients with type 1 diabetes can never be without basal insulin. So this is the structure of Lispro, the first rapid-acting analog. That's also, the brand name is Humalog, and Aspart, which is called Novolog. And this is the sticky end of the molecule they played around. For Lispro, they just switched proline and lysine, and it tends not to glom together as easily. And the group at Novo did another one. They swapped out the proline for an asparagine, and it also is less sticky. And you can see that the time-action profile, looking at plasma insulin levels, is much higher earlier on and a shorter duration of action, whereas regular insulin takes a while and lasts quite a while. So this gives you a better time-action profile. Then a similar take, we're only going to talk about glargine as the prototype, has been taken for longer-acting insulins, modifications that increase the tendency for association. So insulin glargine has a number of amino acids replaced, and because of some of these modifications, it's soluble at a slightly acidic pH. So as opposed to previous long-acting insulins that were cloudy because they were in suspension, it's clear. But once you inject it into the tissue, pH rapidly is physiologic, and these crystals precipitate. And you see that here. It's an acidic pH. Once it hits the tissues, you got all these crystals. They provide a depot effect and a long, protracted time to actually become monomeric. So really, in most people, it lasts up to 24 hours. There's a new formulation of glargine. Insulin glargine, Lantus, is U100. That means there's 100 units per milliliter. They've come up with a super concentrated form, a U300, where there's 300 per milliliter. And every insulin's time-action profile is going to be dose-dependent. The more you give, the longer it's going to act. So it looks like it even acts a bit longer, but it's still this molecule, glargine. So with these modifications, we're able to administer insulin in a more physiologic fashion. So in the past, you had to use vials and syringe. Many people don't like doing that. And we've got great pen devices, and actually these are kind of old now, some even better ones, with pen tips that have very tiny needles that you really essentially can barely feel most times. So it makes it more acceptable, especially patients with type 1 who are taking basal insulin and premeal insulin and corrective insulin. It can be a lot of shots and a lot of testing. There's a syllabus posted as well for people who want to learn about things in more depth. And you can take a peek at this at your leisure, but I just suggest that using various insulins, such as long-acting insulin and regular, regular lasts a long time, you can have merging of peaks. That can cause hypoglycemia. And you can mix and match to achieve what you want. This is kind of regular NNPH is the old kind of split mixed regimen. We have some fixed combinations of regular insulin and long-acting insulins, such as 70-30, 70% long-acting, 30% rapid-acting, and there are a number of ways of doing this. This kind of approach is an older approach, and you're kind of hoping that the regular and NPH are going to cover your lunch. But a number of patterns, just to throw out there. I don't expect you to memorize it, but just to see the options and the fact that we have to think about our individual patients, what their needs are. We want to avoid hypoglycemia. We want to avoid too much insulin at the wrong time. Otherwise, they have to be snacking more. They may gain weight. So it's a bit of a challenge. And we have some great pumps. I just swapped this out. I used to have one that had like $1 here, but the pumps were old. Now they've gotten even better. So this is what people had to do before in terms of continuous subcutaneous insulin infusion. Quite cumbersome. And now the pumps are actually amazing. This is an Omnipod. This is the old Omnipod. The new one is about 34% smaller. It's filled with insulin. There's no tethering like the other pumps, and you control it with a PDM, a peripheral diabetes management device. And we're also familiar with our cell phones and PDAs. And a number of pumps that have inside of them the ability to also communicate with continuous subcutaneous glucose monitor. So this is the Medtronic device with the Enlite sensor technology. This is the Animas Vibe, which is an insulin pump, but also has the Dexcom G4 Platinum sensor, which gives continuous glucose readings, and the T-Slim, the Snap, some newer devices that make things easier. The principle is the same. For the usual ones where there's an infusion set, you fill the reservoir, you prime it, you insert a catheter that has a needle, like an IV, and then you remove the needle and you wear it for 2 to 3 days. Now, no matter how you give insulin, the most common side effect of insulin is hypoglycemia by any form. Patients who wear pumps may have a slightly increased risk of local wound infections. I've never seen anyone get a wound infection from an insulin injection. So more options, and we're doing better. But again, it's subcutaneous insulin, and it's never perfect. So we're going to keep some of these principles in mind when we talk about type 2 diabetes. Just quickly, looking at some of the numerous defects, and this is from Dr. DeFranco's Banting lecture in 2009, when he had given it before, it was the triumvirate, where he just talked about fat, muscle, and the liver. But all of these, and I may say the noxious nonette, because I think, it turns out bones are communicating with metabolism through osteocalcin and leptin, so it's very complicated. Our systems are very integrated. But we now actually have therapies for each of these areas. We're not going to go into all the therapies in detail. We're going to focus on some of the, what the ADA thinks are the most important ones. But we have agents that work. There's an impaired incretin system in patients with type 2 diabetes. We have agents that work on incretin effect. We have agents that can affect absorption. So one of the drugs I'm not going to talk about is the alpha-glucosidase inhibitors. They block starch absorption. The problem with those is they deliver a lot of undigested carbohydrate, and so the joke is we use them in people who live alone in well-ventilated homes. And we've got drugs that work on lipolysis, increasing skeletal muscle uptake. We talked about the importance of the kidney, the brain, the sympathetic hyperactivity. An old drug, bromocriptine, has been approved for treatment of diabetes because it works on that. We're not going to talk about it anymore. The liver is overproducing glucose. We've got drugs that work there, like metformin. The TZDs can help as well. And certainly the incretins can increase insulin secretion and decrease glucagon. The secretagogues, the sulfonylureas and glycides can also do this, but not in a physiologic fashion. So we got 12 classes of antidiabetic drugs today. I think we're going to talk about 4 of them. Biguanides, I think, come first, and the only biguanide we have available in the United States is metformin. Fenformin was taken off the market in the 70s. It required metabolic transformation. About 20% of the population were slow metabolizers that got into the mitochondrial membrane, and it really caused a lot of lactic acidosis. It is still used in the rest of the world. I have patients who come to see me, sometimes from Italy or the Dominican Republic, who are taking this. Metformin's been around for 60 years. The idea came from the French lilac, and it had a lot of guanidine, and it had the ability to cause low blood sugars. And so metformin now is considered the background to therapy if you've got adequate renal function. It's available in an immediate release form and an extended release form. We try to get people up to 2 grams a day, even though you can go up to 2,500 milligrams, because that is where the dose-response curve is best. It does cause some GI upset, so it's not possible to always titrate it up in everybody, but the extended release forms help. It does lower fasting plasma glucose and A1C. It doesn't cause weight gain, and in some studies people lose up to 8 pounds or so. It's indicated for patients over the age of 10. It does not cause hypoglycemia when used as monotherapy. It really is working on the hepatic glucose production arm, so it's reducing this excess glucose production, and it may have some peripheral insulin sensitizing ability. The GI symptoms occur, they usually go away. Lactic acidosis is rare, but when it occurs, it's fatal in 50% of the cases, and usually has been seen. I've actually never seen a case that I believe was caused by metformin, but we see lactic acidosis. It's very serious. So you need to have intact renal function. The drug is not metabolized, it's excreted in the urine. And so in older patients who may have normal creatinines but have poor muscle mass, certainly people over 80, you want to make sure they've got a normal creatinine clearance. It can also lead to decreased vitamin B12 absorption, so it's very important to follow that. And the lactic acidosis is actually quite rare. And for many years, we had no idea how metformin worked. I think the consensus now, probably, although people have differing opinions, is that it's working on that energy sensor I talked about on Tuesday, the AMP-activated protein kinase, which shuts off synthetic things and turns on things to generate energy. So by activation, it's decreasing lipogenesis, it increases fatty acid oxidation, it's decreasing gluconeogenesis, increasing glucose uptake and glycolysis, so it's kind of telling the liver, simmer down. It may also have some effects peripherally in the muscle, because we do see an insulin sensitizing effect to a degree. It could also just be better glucose control and resolution of glucose toxicity. When glucose levels are high, those high glucose levels can stun the beta cell. Sometimes just making glucose is better. You'll suddenly perk up, and you'll see that the pancreatic beta cells have a lot more ability to secrete insulin than you might have thought. The thiazolidinediones were once extremely popular. They're insulin sensitizers. They work by a nuclear mechanism of action. The first one, troglitazone, was taken off the market because it caused fatal hepatic necrosis. Rarely, but when it happened, it was not good. There are 2 available now. They're both available. Well, actually, this one's not available generically. It had a lot of baggage, but recently got vindicated in terms of associations with cardiovascular risk. They lower fasting plasma glucose. They reduce A1C. They usually do raise HDL cholesterol and reduce triglycerides. They may raise LDL cholesterol. They work by improving insulin sensitivity. They take a while, up to 3 months to work. And that's because they're binding to this nuclear receptor, which is PPAR gamma and the retinoid X receptor, and they lead to the transcription, either turning on or turning off certain genes related to insulin sensitivity. So they don't work fast. The problem, they are usually associated with significant weight gain. That can be fluid retention, which some people really retain fluid. It activates the insulin-sensitive mineralocorticoid transporter, so you may be absorbing more sodium renally. And it actually induces fibroblasts to turn into adipocytes, so you actually have more fat. The idea is thinking you get more subcutaneous fat, which is better than visceral fat, and although I think more fat in a fat person is probably not great no matter what. It may precipitate, really probably unmask congestive heart failure because of its increased fluid. There's been an association with both PIO and rosiglitazone of increased fracture risk. We're trying to figure out what that is. It may be diverting bone marrow precursors to fat instead of to bone. The issue of LDL cholesterol, you have to titrate. There's some question in a retrospective database study about bladder cancer risk with pioglitazone. I'm sure you've seen like the 1-800 call a lawyer if you've been on, pioglitazone and had bladder cancer on like the Lifetime channel. And the CV safety with rosiglitazone, really in a review of the trial called Record, has the black box for cardiovascular ischemic events has been removed, but they both carry this warning for unmasking heart failure. So still a useful class of drugs. People gain weight. Most of our patients are overweight, but it's definitely fallen out of favor, but also shown to reduce time to beta cell failure. And I don't know if in any of your other lectures, in the United Kingdom study and the Belfast study, it was demonstrated you've got about 50% of beta cell function by HOMA at the time of diagnosis, and you continue to decline over the years, and nothing really stops it. But in a study comparing sulfonylureas, metformin, and rosiglitazone, as well as Actos or pioglitazone, there was a decreased time to failure. So truly do seem to affect the risk of developing or progressing with diabetes. Insulin secretagogues have really fallen out of favor. They were the mainstay with the first oral antidiabetic agents. These are the first generation. These are the second generation. These are other first generations. And I mentioned that they bind to that potassium channel in a constitutive fashion, so they just depolarize, and so insulin secretion is on. And so there's no ability to deal with hypoglycemia. If you're hypoglycemic, you're still making insulin. They're associated with weight gain, hypoglycemia, sometimes prolonged. Glyburide, along with metformin by the World Health Organization, was considered one of 2 essential drugs for the treatment of diabetes. They revised that when they looked at people over 65 and how many adverse outcomes were happening. Glyburide has 2 hepatic metabolites that are metabolically active and renally cleared, and a lot of the hypoglycemia in the ER is because of this agent, and still even the other agents. So their desirability has fallen down on many people's lists. And there is some evidence that they may actually increase the rate at which the beta cells decline or fail. Just to illustrate the glucose dependency of GLP-1 before we turn to the incretin system, this is a group of patients with diabetes. Their blood sugars are high, over 200. If you don't feed them, they will fall a bit. Insulin levels are flat, and glucagon levels are actually high. If you infuse GLP-1, remember I said normal people, when you eat, glucagon is suppressed. Actually, in type 2 diabetes, for some strange reason, it actually increases. So it's an inappropriate response. If you infuse human GLP-1, which has to be given by infusion, because remember I said it has a half-life of about 90 seconds. So you'll see that there is a reduction of glucose toward normal, and this is accomplished by the appropriate stimulation of insulin secretion. But you'll note that it doesn't keep secreting insulin ad infinitum. As the glucose levels become more normal, there is a reduction back down to baseline. We don't need insulin anymore. So this is the glucose dependency. Same amount of GLP-1 on board. And glucagon is similar in that there is a rapid suppression, but as glucose levels return toward normal, the glucagon goes back up, and this protects against hypoglycemia. So this is a physiologic way of enhancing insulin secretion that's only going, and decreasing glucagon secretion that's only going on when sugars are rising or high. And that's very different than the sulfonylureas, which turn on the beta cell no matter what. So I talked about the incretin system, both GLP-1 and GIP being rapidly degraded by this enzyme, DPP-4. Later on, when I talk about the first injected GLP-1 agonist, I'll show you the sequence that gets clipped. And by blocking DPP-4, certainly these peptides can be degraded by other peptidases, but it prolongs the active incretin levels, and you actually can see a 2 to 4-fold increase in the levels of GIP and GLP-1. And again, because it's working through stimulation of incretins, it's glucose dependent, so there should be a lower risk for hypoglycemia. So we eat, you're releasing your GLP-1 from the L cells, your GIP from the K cells. They rapidly get broken down. If you block this enzyme, the levels rise. They have more of an opportunity to stimulate the beta cells, suppress the alpha cells, lowering glucagon, so you get rid of the hepatic component of glucose production along with higher insulin. And you have insulin to stimulate glucose uptake into the muscles and fat. And that insulin can also reduce hepatic glucose production. And you maintain a more normal glucose levels. And so we have quite a number of these agents available. The first one was sitagliptin, and they're rapidly absorbed. They have a long half-life, once daily dosing. They raise your GLP-1 and GIP levels. They decrease glucagon concentrations. They increase your insulin release. You can see higher insulin and C-peptide levels. And both fasting and postprandial glucose excursions are reduced. And in healthy subjects, they should not lower blood glucose or cause hypoglycemia. You can't say any drug has no risk for hypoglycemia, because people do get hypoglycemia for other reasons. And it's indicated as an adjunct to exercise and diet in patients with type 2 diabetes. It doesn't have a role in type 1 diabetes. And it can be used as either monotherapy if someone can't take metformin, but metformin is always the first choice, or combination therapies, either dual or triple. Most people would go to insulin once you're on 3 drugs. Again, adverse events, really pretty well tolerated. I don't know why in diabetes studies there's an increased reporting of nasopharyngitis. The lymphopenia has been associated with the higher doses of saxagliptin, few drug-drug interactions, but they differ by the members in the class. These are the players. Sitagliptin is the prototypic one. It actually comes in 3 different doses, and in order to maintain the plasma levels of sitagliptin, if you have reductions in renal function, you need to reduce the dose. Only linagliptin does not require a change in dose according to renal function. And this is supposed to be the first one released in the United States, but I think we'll never see it, although it's been used in Europe for years. So very useful oral agents working on the incretin system. More modest reductions in A1C in the order of 0.6, 0.7, compared with the injected GLP-1s, which give you 1, 1.2 or more. And weight neutral. Although even in some studies there's some weight loss seen, but it's certainly weight neutral. We are very into drugs that don't make our heavy type 2 patients gain more weight. We're going to talk about the GLP-1 receptor agonists. I show this because the very first one turns out to have been discovered in the saliva of the Gila monster. It's a southwestern venomous lizard. It's not like a snake. If you happen to walk by it, it like gloms on and doesn't let go and salivates into the wound and gives you all sorts of wonderful poisons. But one of these poisons was discovered at the Bronx VA to be exenatide, and it had a 50% overlap with human GLP-1. This is the human GLP-1. This is the site of cleavage by DPP-4, and you can see that there's a different amino acid. So it's resistant to DPP-4 inactivation. So it's available in two forms. The first form was a rapid acting. It had to be given twice a day before breakfast and supper. There's now an extended release microsphere that's given once a week. It takes about 6-7 weeks to come to steady state and can be associated with transient subcutaneous nodules. But don't worry, no Gila monsters are destroyed in the synthesis of exenatide. It's all recombinant DNA technology, if you're fond of Gila monsters. We've got several other GLP-1 receptor agonists. Liraglutide has 97% sequence homology. It's at a modification to primary structure, so they glommed on a big fatty acid, palmitic acid, C16. It blocks the access to that site for DPP-4. It started in a low dose to reduce GI toxicity. Remember I said these drugs also are central, and they can cause some nausea. They can slow gastric emptying. You can increase to 1.2 up to 1.8. It's once daily dosing. We have a long half-life. And then we've got a couple other long-acting ones that have really just come out last year. Albiglutide is dosed daily, 2 doses. It can be increased if glycemic control is required. It takes some time to come to steady state with these. Remember, your basic pharmacology, you're at 90% of steady state after 3.5 half-lives. So to really get to 100% of steady state, it takes several weeks for a once-weekly agent. And then dulaglutide, which is also known as Trulicity versus Tanzium, again, once daily injected. So a number of options that work on the incretin system. Mentioned the most common adverse side effects are gastric distress, nausea, vomiting, constipation, sometimes reports of diarrhea, usually resolve over time. And the long-acting agonists are associated with less of that because you're building up levels so slowly. There have been post-marketing reports of pancreatitis. I think it was in the slide. And there's also been some post-marketing reports of pancreatitis with the DPP-4s. The cause and effect has not been established. It's being studied in long-acting cardiovascular outcome studies where they're looking at this. So far, the several trials that have been reported have not seen a cause and effect for pancreatitis when looked in a controlled fashion. This Sunday, one of the trials looking at sitagliptin, its cardiovascular outcome study, is being presented at the ADA, but they also will look at risk for pancreatitis. There is a risk for thyroid C-cell hyperplasia and neoplasia in rodents. Rodents have a lot of GLP-1 receptors on their C-cells. Humans really don't. But they essentially got what looks like medullary carcinoma of the thyroid. You can be allergic to it. You can get sub-Q nodules with the slow-release exenatide. So because of this rat data, it's recommended not to give this to anyone with a personal or family history of medullary carcinoma of the thyroid or in patients with multiple endocrine neoplasia. Remember, once you've got neoplasia, you can express any receptors. And there is no cause and effect. Humans and rats are actually quite different. We see benefits in terms of improved A1C, and weight loss is frequently seen and a really happy side effect when it occurs. I showed this to you in the energy metabolism, that 90% of glucose is reabsorbed in the ultrafiltrate in the S1 segment using the SGLT2 cotransporter system. The rest is cleaned up by SGLT1, and you have no glucose. Renal tubular threshold in normal individuals is in the order of 180 to 200 milligrams per deciliter. However, one of the things that actually happens in diabetes with higher glucose, and it may be that the kidney is sensing the loss of glucose in the urine, is that the renal tubular threshold increases into the 200s, mid-200s. So actually it's holding on to more glucose. If you're hyperglycemic, you might actually not want to do that and just let some of the glucose go. And because there are families with a genetic defect, they don't have this gene, they're always glycosuric. And their kidney function is fine. And there's no increased adverse events. And so there are now 3 agents that work on this system. They block SGLT2, cotransporter system. They reduce the reabsorption of glucose by 30 to 50%. So with glucose, you're losing calories. Glucose pulls water with it, osmotic diuresis. So you've got to be careful for dehydration and hypotension, especially in people with impaired thirst mechanisms. But the first one approved was canagliflozin. 2 doses. You can start at 100 and increase to 300. There are some caveats that you need to not go higher than 100 if your estimated glomerular filtration rate is 45. And you should not be using it if the GFR drops. Once a day, otherwise pretty well tolerated. I'll talk about some of the adverse events we can see. Then the second one available was dapagliflozin. Similar effects. They're all quite similar. And then the last one was empagliflozin. So we've got 3, and there are apparently more coming out. They're quite useful. So what are the benefits? Well, by inhibiting this glucose transport system, you lower glucose, both plasma and postprandial. There are significant A1C reductions. You see reductions in both fasting and postprandial. It's an insulin-independent mechanism. No reason to believe that there's an increased risk for hypoglycemia. Although there's been some recent reports of potentially an increased risk for ketosis, especially if it's given to type 1s. That needs to be sorted out, but that's been in the news lately. They are effective at lowering body weight because people can lose 300 or more calories a day, right? You need to have a deficit in calories of 3,500 to lose 1 pound. So people may be losing, a pound every 2 weeks or so until they come back to a new steady state where their metabolic requirements now equal their food intake and the loss in the urine. So it's insulin dependent. There's weight loss. We love weight loss in patients who are overweight. There's a low risk for hypoglycemia. Blood pressure is lowered in the order of 4 to 7 millimeters per mercury, depending on the agent. That's always a good thing. But then caution in someone who's got hypertension, who's on a diuretic. Concerns because there is a risk for polyuria polydipsia. It's not been that much of a problem, especially in younger people. Caution in elderly people who have an impaired thirst mechanism. You could get electrolyte disturbances, dehydration, syncope. It's not really bacterial urinary tract infections that's been seen, but it's really an increase in the risk of genital mycotic infections, especially in women, and especially in women who've had a previous history of yeast infections, which is one way that women present with type 2 diabetes, and in uncircumcised men. But it can usually be dealt with. And then there was a concern for dapagliflozin. There was some imbalance in bladder cancer in the first year of study that has been there. The exact cause and effect is not clear. There were very few cases. This I thought I left out, but just because I mentioned amylin, amylin sticks together. In fact, amylin was named because it was found in amyloid deposits around the beta cell. So this protein forms beta-pleated sheets and essentially laminates your pancreas. So it can't be injected because it would just glom together. So again, modification of the primary structure. It doesn't stick together. It does all the things that amylin does, lowers hypoprandial glucagon, slows gastric emptying, promotes satiety, and pramlintide does the same thing. It's useful really it's indicated for type 1 and type 2 patients who are using rapid-acting insulin. It's an extra injection, so it works quite nicely, but it's not at the top of people's lists. Eventually, as I mentioned, beta cells are failing. That you may not be able to manage patients with oral agents. You may need to add insulin. We usually think about starting basal insulin. And if need be, if that's not controlling people, then we would add a mealtime analog. And so one of the teaching tools is fix the fasting first. If you just drop the curve down, even if you have the same excursions, you're going to improve the A1C. And then if your fasting is where you want it, then you have to think about starting mealtime insulin. And so for most people, A1C of less than 7 is the goal. We do modify our goals. And so this is from the American Diabetes Association recent guidelines. And again, they look at all the drugs that they think are important by their efficacy and their hypoglycemic risk and their weight effects, their side effects, and their cost. Metformin has been generic for a long time now. And they put all of these drugs on an even tier. The order does not suggest the order in which you should use them. You decide the order in which you should use them. So we've got the sulfonylureas, high risk of hypoglycemia, the TZDs, moderate risk of hypoglycemia, very efficacious, the DPP-4 inhibitors, which are a little bit less efficacious than the GLP-1s, which drop your A1C 1 to SGLT2 inhibitors have made it to this list. They're very useful agents, and so these are the drugs that we might be thinking of adding on next. And of course, insulin is always appropriate, and certainly probably the go-to drug if you're very hyperglycemic. And if you failed combination therapy, you may have the option for various triple therapies. One thing that's interesting, I don't see them recommending the combination of a GLP-1 with an SGLT2. It just hasn't been studied. And so we don't usually, if we don't have any data, we don't do it. I don't see any reason why it wouldn't work. But, and then, again, as we continue to fail, considering starting mealtime insulin, or if you're not on an injected GLP-1 receptor agonist, there are studies showing in type 2 diabetes that you get equal reductions in A1C, whether you start glargine or you start a GLP-1 agonist. But certainly insulin is in the future of many people. Again, you can use these as monotherapy if they're intolerant of metformin. You might start dual therapy right away if someone's A1C is greater than 9, because you're unlikely to get below 7. And insulin is always an option in very catabolic people. And sometimes you just treat people with insulin for a couple weeks, and suddenly their beta cells wake up, and you can use one of the oral agents. And I also like the fact that they have certain comments about if your goal is to avoid weight gain, we have the ability to combine drugs either in dual therapy or triple therapy that should not be associated with weight gain, and in fact maybe weight loss. And here I might suggest we could also consider an injected GLP-1 agonist. What if you're, wait, I want to go back one. Avoidance of weight gain, I guess the one for hypoglycemia dropped out. But again, you can combine ones that don't cause hypoglycemia. It turns out that these don't cause hypoglycemia either. Metformin, a DPP-4, and an SGLT2 shouldn't cause hypoglycemia, as well as metformin and SGLT2 and a GLP-1 agonist. When you combine any drug with a sulfonylurea or a glycine, the risk of hypoglycemia increases markedly. And that's just, or with insulin, because you can't regulate the insulin levels. I don't know what happened to the hypoglycemia. And if cost is your concern, which unfortunately it is for many insurers, then you can use these crappier, older, generic secretagogues, which have a high risk of hypoglycemia. You can use human insulin, despite its not great time action profile, because it's cheaper. I hope that this is not the driving force in how we approach therapy. And again, beginning basal insulin, some guidelines. You can start 0.1 to 0.2 units per kilo, and then titrate it up. If you need to start rapid-acting insulin because you're not getting your A1Cs down, then you can take 10% of your basal dose, give that with the largest meal, and drop your basal dose down by that amount. So just some things for you to look at. They're in the slide set. And then the American College of Endocrinology actually has a very nice summary. This is for your information, because you're not going to be responsible for other drugs. But there are a lot of other drugs that we didn't talk about. And they kind of look at them in terms of their potential side effects, and so it's a nice little reference. And then they had their own algorithm. They are much more aggressive with their glycemic goals, and this is the order now. Order matters for them. And they place metformin very high in monotherapy. This keeps moving ahead by itself. And they also place the SGLT2s high, even higher than DPP-4s. Alpha-glucosidase inhibitors are that drug that blocks starch absorption, but they seem to like it. Also works in the incretin system. Turns out that maybe the effect is actually stimulating GLP-1 and GIP. And then dual therapy and triple therapy, it's just another, to throw it out there that there are a number of ways of approaching it. And there are guidelines for insulin similar, but then they're much more aggressive for A1Cs are very high. So that's really a whirlwind tour through anti-hyperglycemic therapy. I would suggest whenever you're going to prescribe therapy to the patient that you sit down at least once and read the PDR, or the package insert for the drugs. There's a lot of good information in there, so you know what the various drug toxicity are. So I thank you for your kind attention, and if there are any questions, I'll entertain them. Perfectly clear, good. Imperfectly clear. Perfectly unclear. this off. Hand it off to you. Yeah. I mean, I like to, but then what they said was that for the pointer, because it's going to be like a podcast, if you use this to do the pointer, it'll be recorded. That's true?
Ah, okay.
So I usually like to migrate and be animated, but
Okay.
yeah.
Okay.
But then I wouldn't be able to use the pointer, and they won't. Oh, I don't point that
Yes.
much.
Yeah. And
Yeah. Well, I signed it. I signed my letter off. The start date, they say it's July 1st. It's not going to happen because it's going to take months to finish. Well, I mean, I'm assuming it's going to happen. You never know until it's done. So I don't know when. Actually, this might have been my last lecture. Oh, that's like, I'm retiring. So, yeah, this is place that 22 years, plus 3 years of residence, so 25 years in total. Scary, but it's a great opportunity. Last Saturday, the diabetes obesity metabolism institute was meeting with Andy Stewart. It's really basic science. He wants to build a clinical research program. So I'm the director of clinical research in Germany, and also the director of diabetes clinical research across the San Francisco. They want us to say Roosevelt of Israel. They wanted me to be the chief demographer at Savannah of Israel, but I didn't want that. Even administrators, it's hey, maybe it certainly was a lot more money. So, you can put the bid on it. And the salary gets reduced every year. And just a lot of resources. By the time I was building, there were filing stuff. I met with the dean, and he had found he loves me. The president of the nursery I worked for him, and he's a psychiatrist. And I was medical school.
oh wow.
And they're putting a lot of money into diabetes. And so it's here is like I'm struggling. And I hate confusing studies because funding is so expensive. Nobody wants to take a research pharmacy class. Who wants an NIH study because the budget's not being cut and the costs are the same. And like the money's kind of on the line. All this stuff with the writings on the wall, the healthcare changes. I see they spending 90 minutes on a panel up and now they're all getting denied anyway. Like I have a guy who's actually the bishop of my church who's been on the toast for 4 years. No longer covered. And even the panel, they insist on putting him on Bydureon. I'm not doing that over the phone. It's odd. I'll see some patients. Okay. So I don't even know how this is going to happen. I'm thinking in
Do you have studies that are still ongoing now?
I do. I need to figure out what I'm going to do. So once I met with you, we had a plan. So we had this one trial, spring, ending in spring, and we've already lost one PI. Dr. Petrolia, the director site. The patients are very. The PI was actually from the University of Alabama. Columbia didn't get spring, which was extensive. Is holding out really in therapy for my God. She's still worried about losing his scalp infection, cannot lose the scalp to the warehouse. So I'm hoping that they'll be flexible on working for us. And unfortunately, we finished like 3 studies, all this money is coming in. I'm going to lose my salary, I don't get a tax distribution to keep all this money. There needs to be some continuity. They're kind of clueless. Dr. Vickers retiring, he's the PI for 3 years. And they're like, we're just going to focus on God, Carl, sorry, you're not coming up. We're like, we have 100 patients in the NIH trial. It's like, and the woman called the end of the show. It's I have relationships. All right, I better run. I got to stop my office, go home, grab my suitcase, and take the train to Boston.
And you're going to be there over the weekend.
Yeah. Enjoy. When did they actually do the cases?
Which case is that?
The diabetes cases?
So we did the DKA one yesterday.
Okay.
And then tomorrow we have the and then we do the so usually it's I'm going to use this. Do I just put in my socket? That's fine. To make it.
No, what was the thing is you don't know, like that, because you don't know what you have.
You know what I mean?
She may have, you know,
Like all of them, they're supposed to be like, as long as you do that, it's supposed to be like where you just kind of step aside and just guide it.
On the other side. Slide it to.
Over here?
yeah, I threw it in there just for them to have, like, some sense of that.
But let me know because that's the one that we could the other two
Oh,
Even the Anarchist Society has some good guidelines. But the ACE and
No, but if you think that the size
ah. But you know what?
we say the goals for therapy, for pressure. So we do mention goals for blood pressure, goals for lipids, aspirin therapy, and now we don't get aspirin. Unless you're
So I added a little thing to that slide that started statin and I put like because the answers are so
especially
Here's my-
15, 5, yes, so over 40 is still in there, and they just updated it a little bit. Last year they still recommended LDL goals. This year they went to the bottom, but they do say you have to.
Yeah, but thank you so much for looking at it. You made me sound a lot smarter. But I gave you credit for when I sent it out to the dance podcast. Not mine. But thank you.
All right, great. Let me wrap.
Take care. No need.
Do you mind things like this? So you can see your next slide?
I actually wanted it like that.
All right, cool.
I apologize in advance. Okay.
Sorry, I'm just grabbing something off this.
Go for it.
Thank you.
Yes. Yes, sir. Okay. Good morning. My name is Dr. Reed, and I'm an endocrinologist, and I specialize in bariatric medicine. I see patients at the Weight Control Center here, along with Dr. Judith Corner, and we have a registered dietitian named Heather Bainbridge that you'll meet tomorrow. And I'd like to thank you for inviting me here to discuss the obesity pandemic and obesity treatment strategies. I have no conflicts of interest. And my objectives today are to review the definition, prevalence, and complications of obesity, as well as guidelines for treatment, and to go through the 3 areas of treatment, including lifestyle, medication, and surgery. So what is the definition of obesity? Obesity is defined as an excess of body fat. But since it's quite costly and time-consuming to measure the exact quantity of body fat that a patient has in an office visit, we use a surrogate measure of body mass index, or BMI. And that's calculated by taking a patient's weight in kilograms divided by their height in meters squared. Now, you can see on this slide that we categorize overweight as a BMI between 25 to 29.9 kilograms per meter squared, and obesity is a BMI of greater than or equal to 30 kilograms per meter squared. And then obesity has 3 different classes as the BMI increases further. You've all certainly heard and seen that the rate of obesity in the U.S. has risen dramatically over the past 20 years. And I'm sure you've also likely seen these CDC maps. And I'm just going to spend just a minute on them to point out that in 1990, there was actually no state with a prevalence of obesity that was greater than 14%. That's the medium shade of blue. If you fast forward to 2010, 20 years later, there's no state that has a prevalence of obesity that's below 20%, the tan boxes. And actually, a third of the states have already surpassed that, and they have a prevalence of obesity greater than 30%. So there's no doubt that the U.S. has an obesity epidemic. And the question is, why do these statistics matter? They matter because having a diagnosis of obesity greatly increases the risk for a lot of other medical diseases. And this slide actually shows you many of them. So the medical complications of obesity are many, and they include obstructive sleep apnea, coronary heart disease, stroke, diabetes, hypertension, gastric reflux disease, multiple cancers listed here, as well as non-alcoholic fatty liver disease. And so it's important for us to remember that treating obesity is not really a matter of vanity. It's actually a way for us to prevent these disorders as well as prevent progression of these disorders. Here you can see the relative risk of diabetes on the y-axis and then increasing BMI on the x-axis. And you see that as obesity increases, there's an increased risk for type 2 diabetes. And if you look at BMI between 25 to 27, that's just starting to get into the overweight category, you can see that already males have twice the risk of type 2 diabetes compared with someone of normal weight, and females have 8 times the risk of type 2 diabetes compared with a normal weight person. And here's another slide looking at relative risk compared with BMI in males and females for multiple disorders, including cholelithiasis, hypertension, and coronary heart disease. And something that's interesting about this slide also is that you can see that even in the so-called normal range of BMI, looking at BMIs between 21 up to 25, you can see that there's actually increased risk for those disorders. And so this is not to suggest that we should start treating patients with a BMI of 23 and have them lose weight so they decrease their risk for hypertension, but it does certainly suggest that patients who do have a diagnosis of overweight, a BMI of 25, or a diagnosis of obesity with a BMI of 30, we really need to focus on helping them lose weight because their likelihood of having these disorders is significantly increased. And while we don't know all of the systems that are involved in obesity and weight regulation, here you see a few of them. And they can include the hypothalamus, which is involved in our appetite, as well as energy expenditure, the autonomic nervous system. There are also some external factors that are important, such as food availability and palatability. You can also see the pancreas, adipose tissue, as well as the adrenal cortex, which is going to secrete hormones that then feed back on the hypothalamus. And you also can get the idea from looking at this that it's quite complex, all of the factors that contribute to obesity. So there are several areas where things can go wrong in any given patient, and also the sense that fixing the problem of obesity is not simple. And you have to realize also that all of the factors on the previous page, those are all on top of each patient's individual genetic makeup, which can give you a predilection for obesity, or a predilection for obesity if you're placed in a specific environment. And here's one example of a genetic problem that can lead to obesity, and this is a mouse model illustrating it. So leptin deficiency, which is patients who don't have the leptin gene, represented by a mouse model here, the OB mouse. In humans, what you see is a phenotype of a patient who's very hyperphagic, they're obese, they actually have decreased energy expenditure as well as a depressed immune function. So they have multiple infections, and their body temperature tends to be quite low. The patients also are infertile, they have diabetes as well as hypercortisolemia. Another example of a genetic cause for obesity is MC4 receptor deficiency. MC4 receptors are present in the hypothalamus. And these receptors, basically you have POMC receptors in the hypothalamus that I'm sure you've heard about from Dr. Wardlaw previously. And when POMC receptors are activated, you have the secretion of alpha MSH. Alpha MSH then binds to the MC4 receptors, causing a feeling of satiety or fullness, and then that causes a decrease in appetite. If you're lacking MC4 receptors, you never experience that sense of satiety, so you just continue to eat. So you can see an example here with this 9-year-old male who is not experiencing that sense of satiety continues to overeat and becomes obese. And these patients also have elevated bone age as well. So you can see the 9-year-old boy, and you can see his brother, who does have both copies of the MC4 receptor present, who's actually a normal weight. Now, most of the patients that we see are not going to have a single genetic mutation as a cause for their obesity, such as leptin deficiency, where you could actually give back the hormone and it cures them. So we need to figure out a paradigm for treatment for these patients. So this is the NIH guidelines in terms of how to treat patients, and it's based on BMI. So here you can see that for patients who have, if you look at the first row, patients who have a BMI between 25 and 30 with medical-related comorbidities for obesity, or a BMI of 30 and above, they should be treated first with diet, physical activity, and behavior therapy. Then, if they don't reach their weight loss goals, then they can be considered for therapy with pharmacotherapy if they have a BMI of 27 to 30 or 30 and above. And then, if they're still unable to meet their weight loss goals, they can be considered for weight loss surgery, the bottom row, if they have a BMI of 35 to 40 with comorbidities or 40 and above. And in that last category for weight loss surgery, patients who have a BMI between 30 and 34.9, if they have comorbidities, can be considered for one specific type of weight loss surgery, and that's the gastric band. And the guidelines for treatment of patients, there was an update recently by the Obesity Society and the American College of Cardiology, which essentially uses the exact same paradigm. The only thing that they changed was that if you have a patient who comes in with a BMI of, say, 30, they state that you don't have to initially start only with lifestyle changes and have the patient fail that. If the patient is presenting and telling you they've got a 20-year history of struggling with weight, gaining weight, and through lifestyle changes not being successful, that patient, you can consider the addition of pharmacotherapy at that point. So now let's go into some specifics regarding the treatment of weight loss. And we're going to start with lifestyle changes. And they really are the cornerstone of any type of weight loss treatment. Lifestyle changes encompass behavior therapy, diet, and exercise. And behavior therapy can include just keeping a food diary. It can be practicing mindful eating. And dietary therapy you're going to hear more about tomorrow. And exercise, I think, is self-explanatory. And it's important to remember that it's not always best for patients to embark upon any type of plan for weight loss if they have a lot of things going on in their life. Maybe they just had a financial loss or the death of a loved one. That may not be the best time for them to work on these things, okay? So in terms of lifestyle interventions, this is a trial that gives us some data in terms of whether or not it's effective. So this is the Diabetes Prevention Program trial, and it was a trial that looked at 3,000 non-diabetic patients. And they had elevated fasting glucose and elevated glucose on an oral glucose tolerance test. And they were also overweight. So they looked at these patients to see, after 4 years, what would be able to prevent or delay the development of diabetes. And they randomized the groups to either lifestyle intervention versus metformin, which you've heard about from Dr. Donovan, which is a medication for diabetes. And what they found at the end of 4 years, you can see on the y-axis the incidence of diabetes, x-axis years out to 4 years, and the group that had the lowest incidence of diabetes at 4 years were in fact the lifestyle group. They did best. They were able to decrease their risk of diabetes by 58% compared with the placebo group. That's pretty good. And they also were able to attain a modest weight loss of 5.6 kilograms. The group that came in second was then the metformin group, and they decreased their risk for diabetes by 31%, along with a 2-kilogram weight loss. So it shows us that lifestyle intervention does in fact work. And here you see another slide that looks at the effectiveness of lifestyle changes, and it has some good news about lifestyle changes and some bad news. So with the good news, you look at on the y-axis weight change, x-axis again, years of treatment. Patients were randomized to either a very low-calorie diet of 800 calories or less, behavior modification, which was behavior change, and a 1,200-calorie diet, or combination of low-calorie diet and behavior change. And what you can see is that patients who were on the combination of behavior change and the low-calorie diet had the greatest amounts of weight loss, and they kept that weight off for the longest period of time. So that's the good news. Again, lifestyle changes, they're effective at weight loss. The bad news about it is, though, if you look 5 years out, all of the patients had regained the weight they had lost. And that's actually quite typical with any lifestyle intervention. And actually 5 years was pretty good. Usually patients regain that weight in 2 years. So the question then becomes, what do you do? What other types of therapies do we have to help patients? And for patients who are unable to maintain their weight loss with lifestyle changes, we can consider medication therapy for them. And before I get into medications that are specifically used to treat obesity, I'm going to actually mention something that I think is just as important, and that's to look at the common medications that patients are on that can be causing or contributing to their weight gain. So here you see some common chronic medications and their effects on weight. So in the first row are antidepressants and antipsychotics. You see the tricyclic antidepressants, SSRIs, and Seroquel. Those are all commonly known to cause weight gain. Compare that with Wellbutrin, which is the only antidepressant that's known to cause weight loss. In the blood pressure category, beta blockers, they don't cause weight gain, but they're known to make weight loss more difficult. Compare that with calcium channel blockers, ACE inhibitors, and ARBs, which are all weight neutral. Then if you look at the anti-epileptic category, and gabapentin is known to cause weight gain in 2/3 of patients who use it, compared with topiramate as well as zonisamide, which both cause weight loss. And you've already gotten a little bit of this from Dr. Donovan. He did mention some of the weight effects of the diabetes classes, and there are multiple diabetic meds, and they have very specific weight profiles. And they're listed here. You see that sulfonylureas, TZDs, and insulin all cause weight gain. Non-sulfonylurea secretagogues, alpha-glucosidase inhibitors, DPP-4 inhibitors are all weight neutral. Metformin, GLP-1 agonists, and pramlintide all cause weight loss. And I should also add to this slide the SGLT2 inhibitors. They also cause some weight loss. So when you see patients come in, a lot of times patients show up at our clinic and they're asking for a medication that causes weight loss. Well, first you should try and work with their provider to get them off of medications that are causing weight gain. And so if they're on, say, a sulfonylurea, why not switch them over to metformin or GLP-1 agonist? And you work in concert with their other doctors, and that's assuming that they're stable, their condition is stable. Right? You wouldn't, if a patient had a recent psychotic break, you wouldn't be talking to their psychiatrist about trying to switch their medication. You're assuming these conditions are stable. And also, as providers, when you're out there prescribing medications, you always want to think about the weight gain potential of medications that you prescribe. Because believe me, if you prescribe a medication to a patient, and 3 months down the line, the patient puts it together in their head and they notice, you know, I've been craving carbs a lot, or I've gained 20 pounds since I started this medication 2 months ago. They're going to stop that medication, and they may or may not tell you. Okay? So it can absolutely affect patient adherence. So now, let's move on to medications that are designed specifically to treat obesity. Orlistat is the first one we're going to talk about, and it has a mechanism that's distinct from all of the other medications. So Orlistat is available in a lower dose that's available over the counter, and it also has a higher dose that's by prescription. And it works by binding to and inhibiting pancreatic lipases that normally break down triglycerides into smaller molecules that are then absorbed into the intestines. But because Orlistat is blocking those sites, the triglycerides remain whole, and they're then excreted into the feces. and about 30% of dietary fats are not absorbed, and patients lose calories in that manner. As for its efficacy, here you can see percent weight loss on the y-axis, time in weeks out to 2 years on the x-axis. And during the first year, patients were asked to be on a hypocaloric diet. So you can see patients who were on orlistat in blue, and by the end of a year, they had about a 12% weight loss, which was significantly greater than patients who were on placebo. And at the end of 2 years, when they were on a eucaloric diet, there was some slight weight regain. However, they still had significantly greater weight loss at the end of 2 years compared with patients who were on placebo. And the most common side effects related to orlistat are gastrointestinal, and they're related to the mechanism of action of the medication. It's pretty predictable because it results in increased fecal fat excretion, and it actually can help patients adhere to the prescribed low-fat diet, because the more fat that you ingest, the more is going to come out on the other end. And it also can lead to a decrease in the absorption of fat-soluble vitamins. So patients are recommended to take a multivitamin separated in time from the medication. And there's a question of liver failure with this medication that's never been adjudicated, because there were 13 patients out of 40 million users over a 10-year period who had liver failure. The issue with this is those 13 patients all either had another medical condition or they were on other medications that could also cause liver failure. But even so, this isn't a medication you would prescribe to somebody who has pre-existing liver disease. So now, as I mentioned, that's a specific mechanism of action, and it's different from all of the other medications we're going to discuss. All of the other medications work by decreasing appetite, and some of them may also increase energy expenditure. And the first ones, the noradrenergic agents, do both of those. So these medications they're Schedule IV drugs. They have a low potential for abuse. That's the same class of DEA classification for Ambien, which is often prescribed for sleep. And they include phentermine, diethylpropion. They're approved for short-term use, so 3 months, and that's because they were approved back in 1959, and back then everybody thought that weight was a short-term issue, that patients would take a medication for a few months, get down to their goal weight, and then they just went on and lived their happy, merry life. And nobody really paid attention to the fact that the people would regain the weight after they stopped the medication. So it's still approved for 3 months. So usually patients will use the medication for 3 months, maybe go on a holiday off the med for a month, and then resume it. Or some patients are just on it off-label long-term. Studies show that patients lose between 2 and 10 kilograms of weight compared with placebo. And some of the more common side effects include insomnia if you take it late in the day. Dry mouth is very common, and palpitations and hypertension. And the remainder of these medications that I'm going to mention are all approved for chronic therapy of obesity, because they've been approved by the FDA within the past 2 to 3 years, when we've all become aware of obesity being a chronic disorder requiring chronic therapy. So the first one we're going to discuss is lorcaserin. And lorcaserin was developed in the wake of fenfluramine, and fenfluramine was a medication that was pulled off the market after it was found to cause valve problems in the heart, and that was thought to be due to its binding to cardiac valves at the 5-HT2B receptor on cardiac valves, because it was a non-specific serotonin agonist. So lorcaserin now is a serotonin-specific agonist. It binds at the 5-HT2C receptor, which is specific to the POMC neurons. And as I mentioned previously with the patient who had the MC4 receptor deficiency, activation of the POMC neurons leads to an increase in alpha MSH. That then binds and activates the MC4 receptors, leading to an increased sense of satiety and a decreased appetite. And that's how patients lose weight with lorcaserin. As for its efficacy, you can see in the first panel, you can see percent of patients on the y-axis, and then there are two groupings, patients who lost at least 5% of weight and patients who lose at least 10% of weight. Lorcaserin group in orange and placebo in blue. And you can see that at least twice the amount of patients on the active medication lost 5% of weight and then 10% of weight. Then if you look at the panel in the middle, there's body weight in kilograms on the y-axis and study week out to 1 year on the x-axis. And again, you see that patients who are on lorcaserin had significantly greater weight loss at the end of the 52 weeks. Panel C shows a very interesting principle about weight loss medications. And what it shows is, again, body weight is on y-axis, time in weeks out to 2 years this time is on the x-axis. And what it shows is, you can see the study group, let's see where I'm at, okay. So you have the placebo group at the top in blue, and they do lose a few kilograms, and then they kind of plateau, they're pretty steady on the way out. You have the group that's on lorcaserin for 2 years, so they lose weight. They have a little bit of weight regain in year 2, but the difference at the end of the 2 years is still statistically significant compared with placebo. But the interesting line is, whoops, that line there, that's the gray line, and that group, they're patients who were on lorcaserin during the first year, and they were then switched over to placebo during the second year. So what you see is that they regained all of the weight they had lost during that first year. They regained it all during the second year. So it illustrates that patients who are placed on these medications for weight, they need to be maintained on them long term in order for them to be effective. And here I have listed some of the most common adverse effects or warnings with this medication. I'm just going to go through a few of them. Most common adverse effect is headache in about 17% of patients. Other ones are fatigue, nausea, hypoglycemia if it's a patient with diabetes, particularly if they're on insulin or sulfonylurea, because those need to be adjusted if a patient starts to lose weight. The dose would need to be adjusted down. And this is a serotonergic agent, so if you put a patient on other serotonergic agents, such as SSRIs, then there's increased risk for serotonin syndrome. These medications are, because it's a neurotransmitter, serotonin, you need to monitor for changes in mood, depression, and it has the risk of causing decrease in heart rate, bradycardia in patients by about 5 to 10 beats. The next medication we're going to discuss is a combination medication, phentermine in combination with topiramate. And I mentioned that phentermine alone is already available for short-term therapy of weight. And I told you that it does decrease appetite and increase energy expenditure. So the increase in energy expenditure is by its ability to increase norepinephrine, and it decreases appetite through an increase in dopamine. Topiramate is actually available as a sole therapy for patients who have epilepsy and also for patients who have chronic migraines. But together with phentermine, it's used for obesity. And it's able to decrease appetite, but the mechanism for that is actually unknown. As for its efficacy, here you can see several groupings for percent weight loss. And I'm just going to go over one of the groupings. So we'll look at the 10% grouping, one up from the bottom, right? So placebo is the dark bar, and then the low and high doses of phentermine topiramate are the lighter bars. So in the placebo group, 11% of patients were able to lose 10% of their weight. Compared with the low or the high dose of the phentermine topiramate, in those groups, at least 50% of patients lost 10% of their weight over the course of a year. The most common adverse effects with this medication were dry mouth. There's the possibility of nephrolithiasis or hypokalemia because topiramate is a carbonic anhydrase inhibitor. Constipation is common, anxiety, dysgeusia, and cleft palate is actually the most concerning issue with this, cleft palate in children born to females. So that's due to the topiramate component of the medication. And the rates of cleft palate in the U.S. the background rate is about 0.03%. But in females who use topiramate for epilepsy, and they take it at much higher rates, much higher doses, their rate of cleft palate was 12%. So that was a 400 times increase. So because of that, and because of the fact that this medication was likely to be used in many females of childbearing age, it was released with what's called a REMS strategy, a risk evaluation and mitigation strategy by the FDA, which meant that practitioners as well as pharmacists were asked to voluntarily take a training program that would inform them of the risk, also make sure that they were aware of how to counsel females of childbearing age on effective contraception means, and also to have females who are on this medication do monthly pregnancy tests because it's an avoidable adverse effect. Other benefits of this medication, here you can see progression to type 2 diabetes in patients who are on phentermine topiramate. And what you see is the darkest bar is placebo, and then the low and high doses of phentermine topiramate. You can see that the incidence of diabetes in the placebo group was 3.7. In the low dose group, it was of phentermine topiramate, it was cut in half to 1.7. In the high dose group, it was cut by 3/4. So there was a significantly decreased risk of progression to diabetes in patients on this medication. Additionally, looking at some other factors, you can see that systolic blood pressure, there was a trend towards a decrease in systolic blood pressure, but it didn't reach statistical significance. But if you look at the bottom panel, there was a statistically significant decrease in triglycerides and LDL cholesterol in patients who were on the active medication in either dose, and there was a significant increase in HDL cholesterol in these patients. So not only are patients losing weight on this medication, but they're also decreasing their metabolic risk. And here we see there's two more medications. This is another combination medication. It's called naltrexone bupropion. Now, I mentioned bupropion earlier when I talked about common medications and their weight effects. Bupropion is also known as Wellbutrin, and it's used as a sole agent for depression. And it's also used for smoking cessation. And here now in combination with naltrexone, it's used for weight loss. And it's able to cause weight loss by activating the POMC neurons that lead to alpha MSH release, leading to a decrease in appetite. And it also can increase norepinephrine, causing an increase in metabolism. Naltrexone is used as a sole agent, FDA approved, for patients who have alcohol or opioid addiction. And here it's being used for weight loss. And it works by blocking the autoinhibition of POMC, leading to a sustained alpha MSH release and then a decreased appetite. So if you look at the figure that's higher on this page, you can see on the y-axis % weight loss, and then on the x-axis you can see time in weeks going out just over a year. The placebo group is in red, and then you can see the two active medication groups, low and high, are in blue and green. And for both groups, there's a very significant difference in terms of weight loss, and there was significantly greater weight loss in both groups compared with placebo. And if you look at the other figure, what they're showing is groupings of weight loss for patients losing at least 5% of their weight, 10% of their weight, and then 15% of their weight. And the top panel is for patients using an intention to treat model, and this is using for patients who completed the trial. So if you look at either panel, if we just look at patients who completed the trial, you can see that in the active groups, the blue and green bars, you see that twice the amount of patients lost 5% of their weight compared with placebo. Same thing going out to the 10% and 15%. So it's significantly greater weight loss with this medication. Here's another slide that looks at about 1,500 patients on naltrexone bupropion, randomized 2-to-1 to the active medication. And I'll just highlight a few of the results. You can see that at 56 weeks, patients who were on the active medication had lost 6.5% of their weight compared with 1% in the placebo group. And if you look at 56 weeks also, there was 50% of the patients on the active medication had lost at least 5% of their weight, compared with 17% of the patients in the placebo group. Most common adverse effects with this medication are nausea, constipation, and headache. And now we're on the last medication that we're going to discuss, and it's a GLP-1 agonist. And you are very familiar with it from Dr. Donovan's excellent lecture. So I'm just going to point out again the effects of GLP-1 agonists that relate directly to its weight effects. And those are its ability to act centrally to promote satiety and decrease appetite, as well as its ability to delay gastric emptying. So that makes a patient feel full faster and feel full for a longer period of time, which leads to weight loss. So liraglutide was one of the medications that Dr. Donovan mentioned. It's a GLP-1 agonist. And in doses of 1.2 to 1.8 milligrams, liraglutide is used to treat type 2 diabetes. But in the 3 milligram dose, it's used only to treat obesity. And in terms of its effectiveness, here you see on the y-axis weight loss in kilograms, x-axis weeks out to 20 weeks. And you can see placebo in green, orlistat, the other medication, in purple, and liraglutide. Just look at the liraglutide, if I can get there, at the bottom. Yeah, that's the 3 milligram dose. That's the one for obesity. And you could see that at the end of 20 weeks, placebo patients had lost not even 4 kilograms, whereas the liraglutide group had lost almost 9 kilograms. So they had double the weight loss at 20 weeks. So obviously, it's quite effective in terms of weight loss. Here you see some of the most common adverse effects and some of the more serious adverse effects and warnings. I'm just going to spotlight a few because you've already heard these. Nausea, vomiting, constipation, fatigue, acute pancreatitis. Obviously, use with caution if patients are on other medications for diabetes. And as Dr. Donovan mentioned, we don't use if a patient has a personal or family history of medullary thyroid cancer, and that's because in rat studies it showed that these medications led to C-cell hyperplasia. So now we're going to move on to the final area of treatment for obesity, which is bariatric surgery. And this slide shows the 3 most commonly performed types of bariatric surgeries in the U.S. You see on the left is the adjustable gastric band, then the Roux-en-Y gastric bypass, and then the sleeve gastrectomy. The gastric band is where the surgeon takes it's a hollow-shaped balloon that's inflatable, that's placed around the upper portion of the stomach, and that's connected to a tube and then a port that's placed in the abdomen for easy access. So fluid can be placed into or removed from the balloon to make room for more or less food to enter the stomach. And that's how patients lose weight. You're restricting the area of food that can be entered into the stomach. Usually with this procedure, patients lose about 40 to 60% of their excess body weight, and it requires frequent visits to the surgeon for adjustments to minimize complications such as reflux disease or frequent vomiting and nausea. And that procedure, along with all the way to the right, the sleeve gastrectomy, they're both considered restrictive procedures. So the sleeve gastrectomy is where the surgeon removes about 80% of the stomach, that area that's in gray. They remove that portion, and then the remainder of the stomach takes on the shape of a tube or a sleeve. That's the name of the procedure. And patients with this procedure lose more weight than the band. They lose about anywhere from 50 to 70% of their excess body weight. And it's believed that even though it's restrictive, similar to the band, they lose more weight because part of the stomach that's removed is the area containing the cell's ghrelin, that's considered the hunger hormone. So it's believed that their hunger levels are going to be lower, and that's why they're going to lose more weight compared with the band that's also restrictive. The procedure in the middle is the Roux-en-Y gastric bypass, and that's both restrictive and malabsorptive. And the restrictive portion is where a gastric pouch is created by separating off a small portion of the stomach at the top, and then a Y limb is created by taking the jejunum and hooking it up to that gastric pouch. And basically then the malabsorption is where you have food that's not going to go through the beginning of the, let's see, food is going to bypass the duodenum and the beginning of the jejunum. And that's an area where usually a lot of nutrients are absorbed. So there's a lot of calories that are not going to be absorbed. Therefore, they're going to lose even more weight than with the other procedures. And not only is it calories that aren't going to be absorbed, but they're also going to have issues in terms of nutrients, vitamins, and mineral absorption. With this procedure, patients lose the most weight of all three. Generally, they're going to be losing about 60 to 75% of their excess body weight. And this is just a slide that shows you for if you have patients later on that have had these procedures, especially the Roux-en-Y gastric bypass, just make sure that they're following up with somebody on an annual basis, such as the surgeon, or that their primary care provider is checking, because these are very specific labs to need to have a selenium checked or copper checked. That's not going to be checked on just a routine annual lab visit. So as far as the efficacy of these surgeries, as I mentioned, the gastric bypass has the greatest amount of weight loss. So you can see that initially, the percent change in weight is on y-axis, time in years on the x-axis, out to 15. You can see that the bypass patients, that's the green line, they lose over 30% of their weight initially, have some slight weight regain over the years, but they come out at about 27% weight loss. Then if you look at the band, the yellow line, they initially go down about 20%, but they have a little more weight regain, and at the end of it, they're at about 12-13% weight loss. And then the vertical banded gastroplasty, that's a procedure that's not particularly performed in the US anymore. It used to be called stomach stapling. It's similar to, the results are thought to be similar to what the sleeve gastrectomy gives, but they're kind of in the middle of the band and bypass. And you can see the control group, which the weight is essentially unchanged. Now, in addition to the weight changes after surgery, which you saw, the patients who had bypass had significantly greater weight loss and kept the weight off for a much longer time than the band. Here you can see that patients who undergo bariatric surgery have decreased mortality. So you note that mortality percentage on the y-axis, years on the x-axis, patients who underwent bariatric surgery had a decreased all-cause mortality out to 16 years compared with the control group. And one of the most interesting findings that's been noted after bariatric surgery, particularly after Roux-en-Y gastric bypass, is the high rates of remission of type 2 diabetes. And here you can see some of the results of the Swedish obese subjects study. So if you look at these two rows here particularly, you can see that 2 years after surgery, the rates of remission of diabetes was 72%, which is pretty impressive compared with 21% in the control group. And then even if you go at 10 years out, there were people, a lot of them had a recurrence of their diabetes, so it's down to 36% compared to 13% in control. But if you think about the fact that one single intervention led to remission of diabetes in 36% of patients, that's still pretty good. And in addition to remission of diabetes, the incidence of new onset diabetes after surgery also decreases. So you can see the incidence of diabetes on the y-axis, and you see time out to 15 years on the x-axis. And control group is in blue, and surgery group is in yellow. And you can see there's a significant difference in terms of the rates of, the incidence in the control group significantly greater than the surgery patients. And the bottom part is essentially showing the same thing. They just broke it out into surgery groups and whether or not they had counseling, but essentially the results are the same. And it's currently unclear why bariatric surgery is resulting in such high rates of remission for type 2 diabetes, and also why they have such great rates of sustained weight loss so far out after surgery. But it's thought that some of the changes in the gut hormones are likely to play a role. And here you see some of the many gut hormones that people are investigating because they're involved in hunger, satiety, insulin secretion, and insulin sensitivity. And I'm just going to go through 3 of these, and then we'll be finished with our lecture. The first hormone we're going to discuss is peptide YY, and it's considered to be a satiety hormone. And it's produced in the ileum and the colon, and it's secreted after a meal, and it's secreted in direct proportion to the calorie content of a meal. Once it's activated after cleavage, it acts as a satiety factor by delaying gastric emptying. It also is able to improve insulin sensitivity. So here you can see the effect of PYY on some subjects, obese and lean subjects. Now these are not surgery patients. So you can see the left panel is all obese subjects, the right are all lean subjects. And you can see that in the top groupings, you see the patients were given saline and then at another point given PYY. And you can see their intake, their caloric intake on the y-axis. And after PYY, you can see that their intake was significantly decreased compared with when they were given the infusion of saline. And then if you look in panel B, it's just showing the same thing but the mean for the groups. And administration of PYY led to significantly decreased intake at a buffet meal. So they had food was available ad lib. So the mean of the group was decreased in obese and lean subjects after being given PYY. And at the bottom, it just shows 24-hour calorie intake, and that also was decreased after infusion of PYY. And I don't have the data here to show, but Dr. Corner, who I work with, she's looked at PYY levels in patients who've undergone bariatric surgery, and what she's found is she's looked at it and comparing in patients who are just overweight controls, patients who've had gastric bands, and patients who've had Roux-en-Y gastric bypass. And what she's found is in patients who had the levels of PYY were lowest in overweight controls. It was slightly increased in patients who had bands, but it was significantly increased in patients who had Roux-en-Y gastric bypass. So that would let you know if patients who had Roux-en-Y gastric bypass had a significant increase in the satiety factor, that might be one of the reasons why they're able to have such significant weight loss and keep it off for longer. Here's another hormone, the GLP-1, which we've discussed somewhat with some of the medications, and it changes after bariatric surgery, and it's thought to partly explain some of the pretty significant remission rates for diabetes after surgery. So this is one of Dr. Corner's studies where she looked at overweight controls, patients who had band, and patients who had bypass. And this is looking at their GLP-1 levels after the administration of a meal test. So you can see that in the overweight controls and the patients with the bands, their GLP-1 levels barely move. They barely go up. But after the bypass patients are given the meal test, they have a robust secretion of GLP-1. So what that means is they're going to have a really efficient disposal of glucose. So that suggests that this really is possibly one of the factors leading to those improved remission rates of diabetes after surgery in the bypass patients. And the last hormone we're going to discuss is ghrelin. And ghrelin's a hormone that is often called the appetite hormone, the hunger hormone, because it enhances appetite and it does increase food intake. So here you can see in the panel that's on the left here that patients who are given saline versus ghrelin, and you can see that after the infusion of ghrelin, the intake is increased. And the middle panel shows essentially the same, but in the individual patients. And all the way on the right, you see there's a visual analog score where patients actually rate their hunger, and after being given an infusion of ghrelin, they actually rate their hunger as being higher. And this figure shows patients who, if it's a single patient, you can see his ghrelin levels on the y-axis and the time throughout the day on the x-axis. So if you look at the bottom lines with the open circles, these are his ghrelin levels throughout the day. And you can see that ghrelin peaks just before the meals, breakfast, lunch, and dinner, And it also has a peak overnight between 12 midnight and 2 a.m. And what's interesting is this patient then underwent weight loss by just diet-induced weight loss. He lost about 17% of his weight. Then the line up top is his ghrelin levels after weight loss. So it still maintains those peaks and comes down after the meals, up and down, but you see that at all times of day, the ghrelin levels are elevated. So this suggests that the patient would then be hungrier at all times of the day. And it's possibly one of the reasons why 90% of patients who lose weight just using diet are going to actually have some recidivism because their ghrelin levels are higher at all times of the day. Here you see ghrelin levels in patients who have undergone gastric band. And you see that at week 0 and week 26, essentially ghrelin levels are the same. But at week 52, there's a significant increase in ghrelin. So that's similar to the patient who had the diet-induced weight loss, compared with a patient who had a gastric bypass, where you see the ghrelin level is slightly, there's a trend towards it decreasing by week 52, not significant, but it most certainly has not increased as it did in the other patients. So again, this might be one of the mechanisms whereby patients who are having bypass are able to lose a lot more weight and keep it off for a much longer time. And here you see, this is just a cartoon to give an idea of as patients lose weight and their fat cell mass is decreased, you see there's a lot of changes in their hormones. You get a decrease in leptin being secreted from their fat cells, ghrelin increases, and these then have feedback in the hypothalamus. And the ultimate goal is that patients will increase their food intake to try and restore the fat cell mass. So these are a lot of the targets that actually medications can try and target to help reverse the cycle and prevent restoration of the fat cell mass if we're going to try and treat obesity effectively in the future. And you may have noted that there's a therapeutic void between lifestyle changes and surgical treatments, because basically there were only 5 medications that were FDA approved for the chronic therapy of obesity, as compared to problems like diabetes or hypertension, where there's over 50 medications for those conditions. The hope is, now that obesity has been designated as a disease, that there'll be more funding put into that and more research. And in summary, the approach to weight reduction, just remember that lifestyle changes are the backbone for all other therapies. Even if a patient goes on to use pharmacotherapy or bariatric surgery, they still need to maintain lifestyle changes to maximize their weight loss. You initiate pharmacotherapy if they're unable to achieve their goals through diet and activity. Set realistic goals for patients, and you should talk to them about if they're going to do pharmacotherapy, and let them know that it's going to be needed to administer for the long term, or at least intermittently long term. And future therapies for medication are more likely going to be of the latter sort that I showed you, that involve multiple medications targeting different parts of the pathway. And bariatric surgery is an option, and it should be considered if patients haven't been able to meet their goals using lifestyle changes and medications. I'd like to thank you for your attention, and I'm happy to answer any questions that you might have. Thank you. Oh. Did I go over? Yes.
Do you feel like uncoupling agents like DNP been studied at all? Because I know he's like in the 30s.
Not recently, for sure.
I don't know. I know it wouldn't be a temporary. It would be a temporary fix to lose a lot of weight. Again, it would be dangerous.
Right.
If you're in a hospital setting, I'm sure it'd be fine. And then they lose like rapid. It'd be a rapid weight loss. I'm sure it's probably. I guess it's probably better than anybody else.
What's the half-life of? What do you know the half-life of?
No, I just know people that use body weight. They abuse it.
Yeah. I'm curious. Well, I'm just wondering, would it be? Yeah, I wonder if is it able to be put into a molecule that has a half-life, right?
I think they do. I remember reading about it a while ago. They did it in the 30s and it worked, but people would get cataracts really fast, and they would like get banned. I don't know. It seems pretty cool. People still abuse it now. They're trying.
I mean, Would you want that?
I mean, if I was obese,
Would,
something else.
you think that would be worth it?
No, but if it's
Cataracts.
I mean, yeah.
At least you'd be skinny, right?
It's like,
I mean, no, I'm saying, but like that's
Blindness.
that's the first analog. So maybe like,
exactly, somewhere along that line. That's interesting. I'll actually ask Dr. Corner. She's worked in the field longer.
Okay,
Yeah.
I just kind of mean along the lines of like athletics. Why do we use BMI instead of body fat percentage? Because I feel like the
Because it's hard to accurately measure body fat, you have to use even something like, so calipers, the reproducibility is so poor. Like, you need to be actually trained. You need to do it 3 measurements. Like, a person actually
the
needs
one
to
of
be trained
those
to do
body
it.
pod things where you like sitting there. Those are super.
Do you know how much those cost?
Yeah.
Exactly. So this is something that BMI can easily, any place in the world, you know what I mean? That's why. It's so expensive, the bod pod. Even calipers, it seems simple. The reproducibility is not very good.
So is that the reason that it's like men usually have more muscle mass than females, right? So is that the reason that as you go higher, like you might have like a BMI of like 30, but like obviously he's more muscular, so his risk of getting diabetes is like 42%.
That's why on the diabetes curve, yeah.
That's
You know,
the muscle
yeah.
mass. Okay.
Yeah.
So
And
if
even
it was based
anywhere
on body
the-
fat percentage, that wouldn't be as skewed like that, right?
Exactly.
It'd be should
If
be
it
the
was
same, right?
based on body fat.
Somewhat.
Exactly. It would be much similar. Because there's also a lot of things, factors in terms of gender that make women have higher risk. Because women who
Yeah, that's what I was wondering.
PCOS, yeah, if you do it just by gender, like polycystic ovarian syndrome, that's something that only females have. That puts them at, if they have insulin resistance, higher body, that puts them at higher risk for it.
So if you take out the body fat,
Pregnancy, they get gestational diabetes, that puts them at increased risk for that. So yeah, if you took that out, it would look different. That's just based on BMI, exactly.
okay, so we're not like innately protected from diabetes.
From diabetes, no. No.
I guess to clarify that question, I meant lefty would be more mitochondrial agents. Yes.
There haven't been any that have been looked at, at least. I mean, it's followed pretty closely. Everything's going on. Yeah. That's an interesting question. Yeah. Do I need to do anything with that, or just? You know, I'm just loud.